Nancy Young. I'm the director of the National Center on Substance Abuse and Child Welfare, and thank you very much for joining us today for the webinar. Let me turn things over to Elaine Stett.
Thanks, Nancy, and good morning, good afternoon to everyone on the phone again today. Thank you again for joining us. As many of you are experiencing in your regions, the opioid epidemic is affecting and sometimes devastating families and service providers from virtually all of the health and human service organizations. I'm really thrilled to see the number of participants on the line, and we have a great turnout. We have representation from the Children's Bureau, from SAMHSA, from HRSA, MCHB, and the ACF Regional Office representation. I know that's the alphabet soup, but I'll go ahead and say it's the Children's Bureau, Substance Abuse Mental Health Service Administration, the Human Services Research, and the Maternal Child Health Bureau, and of course the Administration on Children, Youth, and Families, and within ACF. We hope that when you leave this webinar, you will leave with an invigorated sense of being able to do something about the opioid epidemic in our country. We look forward to learning about and potentially bridging the initiatives that are in your regions. I'd like to turn it over to Dr. Nancy Young, who you just heard from, who is the Executive Director of the National Center on Substance Abuse and Child Welfare. The National Center is co-funded by the Children's Bureau and SAMHSA to address and provide technical assistance and resources to states, tribes, and communities and organizations working at the intersection of child welfare and substance use disorders. I'd like to also just thank our colleague over at SAMHSA, Sharon Amatetti, who is also on the line and has been a wonderful partner in thinking through and organizing this webinar, and also has been incredibly supportive of the work of the National Center as they are the lead organization for it. So with that, I turn it over to Nancy and look forward to the discussion at the end. Thank you.
Great. Thank you so much, Elaine. So we're going to spend a little bit of time today talking about the numbers and then the windows of opportunity, if you will, both about advances in substance use disorder treatment and then specifically about the Child Abuse Prevention and Treatment Act and the changes that were made in that act as part of the Comprehensive Addiction and Recovery Act, or as commonly called, CARA. And then some lessons that we've been able to gather at the National Center related to some technical assistance programs that we've been conducting for the last few years. Hopefully we'll have some time for some discussion and then open up for some ideas related to some next steps. So as Elaine mentioned, the National Center on Substance Abuse and Child Welfare is a program of the Substance Abuse Mental Health Service Administration and the Administration for Children and Families, and our direct contacts are in Children's Bureau, the Office on Child Abuse and Neglect, and the Center for Substance Abuse Treatment. We are in our 15th year, so we're very happy to be able to have gathered some knowledge over those 15 years about the various substance use trends that we've seen over those decades, but also to make sure that we're staying current with what the knowledge base is about the impact of substance use on the child welfare population. I see that there's a little bit of a drag on from my screen to what you're seeing, so I'll try and make sure that I'm timing this a little bit better so that we don't have too much of a drag. So you're all very familiar with the trends over the decades of the heroin epidemic that we had in the 1960s, cocaine in the 80s, methamphetamine in the 90s, and now the prescription drug and opioid crisis that our country is facing now. And I think part of the lessons from these prior trends in substance use is that it's so critical to make sure that we're looking at the impact on families in regard to what's happening for the child welfare system, for income support programs. We had a conversation yesterday about the impact in child support and how substance use disorders may be affecting their programs and the window of opportunity that they have even in child support. So we recognize that there are many lessons from these prior eras that we need to bring into the programs that are being conducted across the nation now. In 1997, as you are all very aware, the Adoption and Safe Families Act set some new criteria specifically about timing and many other aspects of the child welfare system. Since that time, SAMHSA and ACYF have had several initiatives that have helped us understand what the impact is, and then I think importantly, what kinds of strategies, what kinds of program, what kinds of approach we put in place to improve the outcomes for this particular set of families. So you see the various grant programs that have been funded and all the way through February of 2017, and the Policy Academy that brought several states specific to this topic. And we'll talk a little bit into the webinar, into the session, about some of the lessons that the National Center is gleaning from the work of the states that participated in the Policy Academy. So telling you kind of the summary of these data slides that I'm going to show, what we know is that there are more children that are recorded in the data system that are removed from parental care when substance use is a factor. There is an upward trend in children in out-of-home care. Disturbingly, more infants that are entering out-of-home care than any of the other age groups when we look at entrance into out-of-home care by age. And then also that the impact for extended family members who are caring for the children who are affected by substance use, it looks a little different than perhaps what we even saw in the cocaine or the methamphetamine epidemics. So some data to get started with. These are probably data that particularly those of you who are the program managers from Children's Bureau are very familiar with. Perhaps our colleagues in other agencies may not be as familiar with, but these are the static population on September 30th of each year. And after many years of this downward trend that was very effective in reducing the number of kids in out-of-home care, as was one of the primary goals of the Adoption and Safe Families Act, we began to see an uptick in 2013 in that population, as well as when we look at the data that are recorded in the SACWA systems, the Child Welfare Administrative. There are optional items for caseworkers to enter if the parent's alcohol or drug use is a contributing factor for the reason for the removal. And you see, while even during the time period that the overall rates were going down, more children identified as being moved with a parent with an alcohol or drug use issue. Most times when we present these data in live audiences in states, we tend to ask, does this look like data that are reflective of your state's experience? Typically, we get a lot of no's. That's not what they experience. But the reason why that overall data is that way on that about 1/3 of cases is the wide variability from state to state. Now, we think there are two things going on with this. One is the system that the state has to screen and to identify parents with a substance use disorder. And then secondly, the system to actually record that in the information system. See this wide variation from state to state. You can see the states that are in your region. Probably there are not huge prevalence state by state differences within your region. But if you look at states in your region, you may find very big differences from state to state in what actually gets recorded in the information system. So some of the work that the National Center has been doing over the how will they have a standardized screening assessment protocol to identify families who are in need of services, as well as that second component of the information system. So we'd be happy to follow up with any of you that would like other data related to this, but we encourage you again to look at data from your state and you know, just be in touch with, does that seem like what you're hearing from your state leadership? I mentioned already that one of the aspects of the opioid crisis is the impact on multi-generational families. We certainly saw that in the cocaine epidemic. We certainly saw that in the methamphetamine epidemic, but we haven't seen the number of overdose deaths that are really in our country before. So while extended family have always stepped up to provide kinship services, kinship care for the children with parents with a substance use disorder, this is a larger increase than we've seen in the past as we look again at those AFCARS data about children who are placed in kin providers, that they tend to be a higher percentage of those that were noted in the case record that they had substance use disorders. So again, those are just secondary analyses that we've conducted based on the AFCARS data set, but it may be something that you're hearing from your state leadership about the impact on extended families. I mentioned this one already in terms of these are children who entered out-of-home care during the fiscal year, and the increasing trend for younger population that's really being driven by infants. So less than 1 year, about 47,000 infants in the country who are placed in out-of-home care based on the safety and risk factors that are evident in their family while this child is an infant. When we look at what we get the, well, let me back up and say we get the question a lot. You know, what do the data say about the impact of currently opioids on the foster care system? And running through those data, you can understand why we have to say, well, we don't really know that direct connection. But one of the things that we are certainly aware of in the infants are the percentages and the numbers of infants who may have potential effects from prenatal exposure. And these are simply the national estimates of substance use during pregnancy applied to the 4 million annual births. So it's not precise to say that these are other than these national estimates that are applied to, again, to the annual birth. So, but you see that about 15% of women continue to smoke during pregnancy, use of alcohol at 9%, illicit drugs at 5%, binge drinking, which can be particularly concerning in the first trimester, at a much lower number, and heavy drinking again at a smaller number. And then these are the data of infants that were diagnosed with neonatal abstinence syndrome. Those are from the Medicaid data that have been published and looking at the increasing trend of NAS in Medicaid claims. And then again, the smaller percentage of infants that are diagnosed with fetal alcohol spectrum disorder. So the part of the reason for putting these data out is that it relates directly to the Child Abuse Prevention and Treatment Act because there are 3 populations that are identified in CAPTA for CPS to be aware of and for hospitals to take action regarding. And that first is this potentially affected by prenatal exposure. So when you apply those percentages to the births in any one state, you begin to get at least a feel for what the potential population is. These are obviously not direct consequences, but a way to at least look at what is that potential population. And then the second category in CAPTA, and we're going to get into that in a little bit of detail in a bit, are those infants who experience withdrawal symptoms. So this narrow population of actually being diagnosed with neonatal abstinence syndrome is this withdrawal syndrome. And then infants who are diagnosed with fetal alcohol spectrum disorder. So again, just some ideas about ways to look at the data to get a little bit of a handle of what's going on in your own region. I mentioned that the data on neonatal abstinence syndrome, or NAS, come from the Medicaid claims data, and the most recent is a study that was done based on 2013 claims, and you see over the past almost 15 years this increasing trend on the rate of NAS over time. And the same researchers have have looked at the regional variation from the hospital rates to establish the rates by region in the country. Knowing, and this is directly from their study that you see the citation for if you want to get further information on that for your own particular region. But knowing that there are the infants that are going into out-of-home care, we used the same regional breakdowns that these researchers did and looked at the rates of infants that were placed in out-of-home care. So it's fairly interesting that doesn't overlay. We did this in part to try and understand, is there a relationship between the higher rates of NAS and infants that are going into out-of-home care? And for those of you that are in the regions from Montana to Arizona and New Mexico are probably very aware that that part of the country is still experiencing more methamphetamine use disorders than opioid use disorders. While we certainly have reports that opioids are affecting those regions rather, not in the same way that they've continued to experience the methamphetamine challenges. In addition, we have, and I think one of the things that you may be monitoring, we have more anecdotal reports from some of the Northeast corridor and the region from Michigan down to Alabama that they're seeing increasing trends again in methamphetamine use disorders, even in the throes of the overdose death crises that particularly the Appalachian states are experiencing. When we turn our attention to NAS, or neonatal abstinence syndrome, I think many of you are very, very aware of what this looks like, that the symptoms begin after birth and what that may look like. We do know from the mother's study that was conducted some time ago on pregnant women with opioid use disorders that some of the onset is related to the characteristic of the drug use and the timing of the last dose. We also know that most opioid-exposed babies are exposed to multiple substances. But we also know that there's this wide variation in the experience of NAS or the diagnosis of NAS among exposed babiys. And that medication is required in about half of those that express those symptoms and are diagnosed with NAS. So we have this wide variation of among pregnant women who use opioids, what percentage actually would be identified with an infant with NAS, and then the requirement or the need for medication for those infants. This is a study that's very new in the literature, just actually last month in pediatrics. And it reports on researchers in the NICU at Yale University Hospital. And over a decade, they set out to try and reduce the NICU stays and the impact of NAS on infants. And over that decade, conducted a series of mini rapid cycle testing series to try different kinds of approaches about what they could do to decrease the NICU stays and the impact on their hospital, as well as to increase the outcomes for the infants and their families. So you see the kinds of interventions, the non-pharmacological treatment, while giving morphine as needed, but the rooming in with the parent, the quiet environment, not immediately placing the child, the infant rather, in the NICU, that the infant was roomed in with the parents whenever possible. So they stopped the immediate, all these babies go to the NICU, and did some very focused parent empowerment about how the parent could soothe the baby first. And then the changing a bit of the way that they were assessing for the symptoms and teaching parents how to assess for the symptoms, and making sure that there was good communication between their units of the NICU when needed and the regular maternity area of the hospital where babies may be rooming in with their parents. So over that time period, they were able to decrease the NICU stays of, and you see the outcomes dramatically, that they also decreased. It was almost a standard practice that babies would receive morphine during that withdrawal syndrome to just about 14%. And obviously dramatic implications for their NICU costs. And finding that there were not any infants that were readmitted for treatment of NAS, and no adverse events were reported. So you have the citation there. I would encourage you to take a look at that and to share that with your states. We think very interesting research, as well as implications for public policy that we need to be paying attention to. We do know from, I mentioned the mother study, which was conducted a few years ago, but we do know that there are many factors that affect the infant's manifestation of full withdrawal syndrome, as well as the longer-term outcomes for the infants. Receiving prenatal care is critically important. So maternal and child health plays such a huge role in making sure that these moms are engaged in prenatal care. Exposure to the multiple substances, again from the mother study, some of evidence from that research that also smoking and using opioids tended to increase the severity of the NAS symptoms. What that means in terms of the childhood experience, particularly for the infant, if they're afforded those opportunities to bond with their birth mother, when that can happen safely, how important that is, as well as some of the other health and psychosocial factors that may be evident with the family that need to be sometimes remedied and sometimes be aware of in terms of the child's long-term impact. There's also a consensus statement that was recently issued a couple of years ago from the American Academy of Pediatrics. It's not actually a meta-analysis, but it is a consensus among the researchers that have been looking at the short and long-term effects of substance exposure on infants. A lot of this research began again in the cocaine epidemic. There are several studies from the 70s on opioid-exposed infants, certainly more studies that have been done on alcohol and tobacco than the illegal substances. But you see the kinds of outcomes that the researchers were looking for to see as they looked at this whole body 30+ years of research on the effects on children, the kinds of outcomes that they were looking for. And on the next slide, I apologize for the blurriness of this. We reproduced this directly from the article that was published in the technical report for AAP. And you see those areas of the substance in which there is not enough information, those that have the star, those in which they did not have a consensus on the effect. And then you see those that have been studied and shown to have no long-term effect, or a large effect, or a strong effect rather, and across each of the different types of substances that infants have been exposed to and have been researched. So while we see this immediate strong effect of withdrawal from opioids, if you look across that withdrawal line, opioids is the one that has the strong effect, not enough information on methamphetamine, but the other kinds of substances don't have that immediate withdrawal impact, but may have longer term kinds of consequences, particularly in behavior and neurodevelopment, cognition, language. So I think this is a very helpful way for us to be looking at both the short-term and birth outcomes as well as the longer-term effects. And we're happy to be able to share this information with you because I think it's a lot of what policymakers are trying to understand what happens when infants are exposed to these various substances. So again, you have the citation. Please let us know if you have any difficulty with locating that, and we can make sure that you get access to that. So windows of opportunity, what do we do with all of this data? What do we do with all of this information about the impact on families? So we want to spend a little bit of time, and for our SAMHSA colleagues, where this is information that you are very familiar with, but wanted to make sure that our friends in ACF and maternal child health, HRSA, other areas of health and human services also has some of this information. And then we'll turn our attention specifically to what the changes have been in the Child Abuse Prevention and Treatment Act, and then what we have been learning from the states that we've been working with. First, let me turn things over to our IT staff. We're going to launch this poll. Just a few ways to kind of engage you a bit. So the first polling question, medication-assisted treatment is used to treat a variety of substance use disorders. I'll give you a few seconds to respond to that. Click your response. Yes, in fact, there are medications for a variety of substance use disorders, so a very knowledgeable audience that we have already. So turn things back. Again, this is information that's very well known to our SAMHSA colleagues, but the advances that have happened in understanding their neurological advances in the brain disease of substance use disorders is quite remarkable over the last decade to decade and a half. When we say it's a chronic brain disease that affects judgment, impulse control, and memory, we know that from the studies of the brain and the reward pathway and the connections to the frontal lobe in decision making. So if you're in the child welfare system and you're working with families that have a brain disease that's affecting their judgment, their impulse control, and memory, you can imagine that the approach to this set of families may need to look a little different than families with that are not impacted by this brain disease. That we know that there are a variety of factors that contribute to its development, and importantly, that it is in fact a treatable disease. That there is hope and that there are ways in which individuals recover. If you're not familiar with the principles of effective drug addiction treatment, this comes from NIDA, and we can make sure that you have copies of that for your states if you're interested. But we wanted to highlight this component about medications as an important element of treatment for many patients, and the importance that we like to say we want to always make sure that we're saying it's medication-assisted treatment, because medications need to be combined with the counseling and other behavioral therapies in most cases, and making sure that families are getting access to both. We have another poll coming up, but we have already looked at this, that there are medications for a variety of substance use disorders, and we have polling question number 2. Is medication-assisted treatment to treat opioid use disorders in pregnant women safe? Sometimes, certain medications, yes, it's recommended by ACOG and the World Health Organization and the American Society of Addiction Medicine. Yes, abrupt discontinuation of opioids often results in relapse, and yes, in conjunction with counseling and other services. Okay, about half of you shared your views. We'll go forward. And most indicated all of the above, and we would agree with you that these are all things that are specific to the use of medications with pregnant women, that again, ACOG, the American Society of Addiction Medicine, and the World Health Organization recommends as a clinical standard. Of the medications that are available to treat opioid use disorders, these are the names that I'm sure that you have seen in even the mass media or regular media of understanding Narcan, of reversing overdoses, the extended release of naltrexone, that is a once-a-month injection, and we recognize that some states are using that in conjunction with the criminal justice system because after release from incarceration or after a period of time of abstinence is a very risky period for overdose, as well as those that have been researched as to be used during pregnancy. So methadone and buprenorphine in the subutex form are those that have been studied for use during pregnancy. The goal of providing medications during pregnancy, when we certainly get media reports about how could you do this during pregnancy and how could ACOG and ASAM and the World Health Organization say we should be giving medications during pregnancy. If we think about the goal of stability for the pregnant woman and the fetus, the studies that have been done show the high relapse rate for return to opioid use after periods of abstinence, and that the stability for the pregnant woman and using medications helps to provide that stability for the fetus, and that's really one of the goals of assisting treatment with medications during pregnancy. When we say it's a standard of care, there was, in fact, a public release just this week from ACOG again on reiterating the standard of care with medication-assisted treatment with counseling during pregnancy. And again, some of that information that we just talked about, the cyclic withdrawal that the fetus experiences, if the pregnant woman experiences that, is part of the need for making sure that there's good prenatal care going on, as well as decreases in other substance use, the reduction in acquiring HIV or HCV during pregnancy, again, the risk of overdose, and providing that increased opportunity for stability for the pregnant woman and the fetus. So each medication varies in its ability to prevent or reduce the withdrawal symptoms and the craving symptoms. And we think it's important that we recognize that medical doctors should be those that are making those determinations of which medication, the dosage and the duration. You have probably had phone calls from your states about sometimes policymakers or judges that insert their way of saying that this is what they believe should happen for medications. And we think it's important that we're relying on our healthcare system and our physicians to make those determinations about dosaging and medications during pregnancy. So we're going to turn our attention to CAPTA-specific kinds of information. So our next poll, what does CARA, the Comprehensive Addiction and Recovery Act, have to do with prenatal substance exposure? I think I already told you this answer. So we should have 100% voting. All right, let's see what that result looks like. Yes, in fact, this is a very knowledgeable audience we have, because many times I've been making presentations around the country, and I mentioned CAPTA and CARA and what does it have to do with infants with prenatal exposure, and no one seems to know. So we're delighted that this is a very informed audience, that in fact the Child Abuse Prevention and Treatment Act was changed, and that it expands the plan of safe care that's required when an infant is identified beyond the needs of the infant to also address the needs of the affected caregiver. So this is a true opportunity to be able to look at the way we construct family-centered practice and interventions for this set of families. This is a summary in case you're interested in the various changes based on 1974 and CAPTA's origination. The first change in 2010 that included conditions for the state grant. We'll talk about these a little bit more in detail. This is pretty small on this screen, but we wanted you to get the sense of 2003, 2010, and 2016 are the changes that were made in CAPTA. And we also want to point out that in each of these changes in CAPTA, it was established in 2003 and has continued that while there is a requirement of a notification from the health provider to CPS, that the notification shall not be construed to establish a definition under federal law of what constitutes child abuse or neglect or require prosecution for any illegal action. So states vary. You know that probably even within your own region about their state statutes regarding this population. And we always think that that's the place to start, is understanding what the state statute says right now about how they address this population in terms of substantiated child abuse or neglect based on their state statute. So the primary changes that were related to infants with prenatal exposure in 2016 was first to clarify the population. So born with and affected by substance abuse, remember that left-hand component of the prevalence slide that we looked at, or withdrawal symptoms resulting from prenatal drug exposure, or a fetal alcohol spectrum disorder. What's unique is that it specifically removed illegal. So born with and affected by used to say illegal substance abuse, and now it says affected by substance abuse. So you can imagine that these are some of the challenges I'm sure that you're hearing about from your states about how to implement this with families that may have an infant who's affected by a legal substance, particularly in the area of marijuana and the changes that we have across the states in both legal marijuana use as well as medical marijuana, and some states in which it has not been made available for medical or for legal use. So what we think is important in that is to make sure that we're talking about those substances as it relates to risk and safety for the individual child. When we talk about the legal substances, that it's about, is that place that child at immediate safety concerns or risk of chronic neglect? Are there other things that are being reported besides just the substance use? The second component is this requirement that the medical provider is to notify CPS of infants that are identified in these three categories, and a plan of safe care is to be developed that addresses the needs of both the infant and the family or caregiver. And the family caregiver is the add in 2016. It specifies data to be reported by states, and it increases the monitoring and oversight for states to ensure that plans of safe care are implemented and that families have access to those appropriate services. So many changes that, as you all know, have created an increased awareness in the states about what they have been doing related to plans of safe care in the past, as well as trying to understand the implications for their implementation in their states. So Children's Bureau has released 3 program instructions and an information memo. We wanted to highlight those in case you haven't had the opportunity to read those or to have those in your toolkit as you're working with your states. But first, in April 2016, that asked states to describe what they were doing. I'm sure all of you were, those that are on the Children's Bureau side of the House in the audience have been reading those and understand that. And then in August, an information memo that was information about the changes that went into effect in July of 2016, as well as highlighting some of the promising practices, particularly related to collaborative practice and how states and communities put these services together. Again, program instruction, in January 2017 that provided clarification, and the program instruction in April related to the reports that were just turned in for the state plans. So in that era of these increased changes, the National Center on Substance Abuse and Child Welfare, under the leadership of our SAMHSA and Children's Bureau, have had a variety of initiatives to look at the local and state implementation. First, last summer, hard to believe it's a year ago now, was the release of a monograph that was done in conjunction with a team of about 40 professionals from across disciplines and across the country to provide guidance to states on implementing a collaborative approach to treatment of pregnant women with opioid use disorders. The appendices of this monograph include ways for states to come together to assess their practice now, as well as for local communities to understand the way in which families are identified and what their system looks like at present in order to identify the priorities about their practice and state changes that they may need to better serve this population. We also want to make sure that you are aware of the information that's available on the National Center on Substance Abuse and Child Welfare's website. We've conducted a series of webinars on the full scope of medication-assisted treatment to treatment of pregnant women, treatment of NAS, and the information that's available in the monograph that was released last summer. So we know that some communities are coming together watching these webinars that are in the library and then having their policy and practice discussions about what their implications are in their own community. We also adapted a program that the National Center had been conducting. We refer to it as in-depth technical assistance. We've been in just over half of the states in providing assistance to states in strategic planning on this broader population of substance abuse, child welfare, and courts. In 2014, we adapted that to be specific to substance-exposed infants, to provide assistance to states to advance their capacity. And you note that this was created even before the changes in the CAPTA statute. So we've been focusing on this for some time about what it takes for states to actually implement the changes that are needed to have this collaborative approach. You see the states that have been part of the in-depth technical assistance that was tailored to implement practice and policy changes specific to this set of infants. At present, Delaware and New York are active in-depth technical assistance sites, and the other states are in various stages of post-IDTA follow-up and implementation. I mentioned previously that Children's Bureau and SAMHSA supported a policy academy in February of this year, and you see the states that participated, as well as the states that had been part of the in-depth TA came to share their experience in a bit of a mentor role for the new states. So from this experience with these various states in these different programs, we've tried to categorize the challenges that they've told us about, but also the turning that around a bit to the opportunities that have been identified by states in the area of practice and policy that they've needed to address. So first, in the area of prenatal screening, really trying to understand, does prenatal screening happen in private practice or public health clinics, in the MCH programs, and to understand some of the reasons that OBGYNs were giving us about why it doesn't happen. And often it was about these kinds of things that are listed in the bullet points. And frequently we heard, even if they screened, they didn't really have the expertise or to know where to send that individual pregnant woman for the next step. If someone breaks their arm, a pregnant woman breaks their arm, there's an orthopedic physician in their network, probably a colleague that they know in their community, that they would be referring that pregnant woman to. If it's a substance use disorder, they may not know who the provider network is in their community. They didn't really know, what do I do as a next step if I screen? And you see some of the other things that physicians in particular and community providers told us about why they think or why they didn't conduct screening, as is a practice that is supported by ACOG, that all pregnant women should be screened, why that really wasn't happening. A second area was related to understanding medication-assisted treatment. And then we heard, not only are there OBGYNs that are reluctant to have patients with opioid use disorders in their caseload, but there are also opioid treatment providers who are reluctant to have pregnant women in their caseload. So we have this gap on both sides of the delivery system, as well as the need to make sure that the treatment resources were culturally appropriate, evidence-informed, and gender-specific, that there are some real gaps in the treatment network for this particular population. The third area was about having a protocol at the hospital. At birth, how are these protocols implemented? Is there a protocol about how they identify infants with prenatal substance exposure? We looked at the protocol at Yale and how they changed that, but that's very rare. We don't hear that too often on having the other kinds of non-pharmacological approaches always being implemented in the hospital. There's often reluctance to follow up to do the notification. Who is supposed to do that in the hospital? Is that the hospital social worker's responsibility? Is it the OB who's delivered the baby? Is it the nursing staff? So inconsistent protocols about how that hospital notification was to happen. And then also the awareness that the hospital discharge plans often didn't address the mother or the caregiver's substance use, and that typically at this point that there are not plans of safe care that are being developed that address the infant, the family, and the caregiver. So we kind of are looking at this as sort of the standard practice right now. We also know that there are challenges about making sure that there's ongoing support. How do we know that the infants that are that do become part of the caseload of child welfare services, that they're getting the early intervention services that are required as part of Part C? The home visiting providers who may not be equipped to work with pregnant and parenting women that have substance use disorders, what kinds of training do they receive? How do they engage families, particularly the new mother or the pregnant woman in these voluntary services? We know that there's a lot of variation and lack of medical coverage for the continuing care and the follow-up for postpartum services, particularly in states that were non-Medicaid expansion states. And while we know that Medicaid covers about half of the prenatal care and birth for infants and their families in the country, it varies a great deal about what the postpartum coverage is under Medicaid. And again, making sure that the services are reflective of gender-specific services that are needed. So we talked about those kind of 4 areas of information related to practice in the policy, and then some lessons that we've learned about collaborative practice that is needed in the states. So first, some lessons about how to structure the collaborative. We recognize that when we talk about these kinds of health, social service, other kinds of services that need to be put in place for families, there's no one single agency who, if you will, has the ownership of this population. It's multifaceted, it requires multiple agencies, and the foundation of collaboration about having a purpose for this set of families often isn't necessarily in place right now. We have to have the ability to look at the differences in disciplines and values and to reflect the local community's values and the outcomes that they want to achieve. Much of our collaborative work, we try and help communities and states really focus on the resources across these agencies. What are the rules that are preventing services from being able to be delivered in a coherent way for families, and a real focus on what does that community, what does that state want to achieve in the results, so that they have the glue, if you will, to hold this collaborative together. We also have been a little bit more prescriptive in the last, I'd say actually decade, than we were in the first 5 years of the National Center, and trying to work with states in creating these major system changes and collaborative practice. In that we have found over the years that if we don't structure the collaborative in a way that produces results so that each of these different levels of the system have some specific roles and responsibilities, that the collaborative often becomes just a bunch of people talking and sharing the most recent things that they have done in their own agency. We are sometimes referred to that as a bog sat, that is a bunch of guys and gals sitting around a table. And we try and really help states and communities move from sharing what's the latest thing that's happened in your agency to be very focused on what are the results that we want to see in that community, that they want to see in their community, and how do they structure that collaborative work so that it becomes a way in which they're really working together in a productive way. And we know that that takes leadership. That is leadership at each of these different levels of the system. From the oversight committee, it's not just the state director. Leadership sometimes happens from the family treatment court coordinator, or the public health nurse, or the person who is overseeing the home visiting programs. That the leadership happens in various areas, and part of our task is to understand who those leaders are and to help them create the change in their community. We also know that this is an era of increasing complexity for child welfare agencies. They typically are not natural partners with hospitals, other than perhaps getting referrals from them. They may not be as tied in with early intervention providers or the Department of Health or their home visiting programs. And that reaching out to Medicaid to understand what's going on for the families that are in the child welfare system or in substance use disorder treatment, those are new relationships for many of these agencies. And it's challenging, just as we know that over the 15 years of trying to help substance use disorder, child welfare, and courts build these collaborative structures. When you add the new partners from the healthcare arena, we often say it's not additive, it's exponential in the complexity, because they all have their own disciplines and funding structures and ways in which they are conducting their own business, that it becomes even increasingly more complex. But we also are hopeful that we know some things about how to engage, how to assess the standard practice, and how to bring them together to create ways in which they're working together and focused on those outcomes. We also have some lessons from the states about the data collection, reporting, and data integration that is needed in order to respond to the increased reporting requirements in CAPTA. We know that there are some states that have made changes in their information systems that are specifically addressing the items that are in CAPTA that are to be reported in the annual report. But it also means that practice and the policy protocols that I mentioned about, if you have a screening, are those results actually getting into the information system? So the practice protocol, the training on that, as well as the policy for the particular state about how they are to enter that information, and importantly, how supervision happens to know that screening and assessment has happened. So here's a pop quiz. We have another polling question, if we can launch that. So we just talked about the current CAPTA provisions requiring prenatal substance exposure. So read through those options. What does the new CAPTA requirements include? And clearly a very attentive, smart audience we have going. So thank you very much for indulging us with that. Everyone recognized that these are the changes that we've just been talking about. I'm sure many of you were very aware of those changes even before this presentation. When we think about what are the immediate state considerations, it was interesting. I was at a three-branch institute. Many of you are probably aware of that, when they bring together the judicial, legislative, and administrative branches in strategic planning kinds of efforts. And one of the gentlemen that talked about the efforts that they had been making in specifically related to substance-exposed infants, they had passed some state legislation, but he said his most important advice to his colleagues was to make sure that they had a clear definition of what is an infant affected by substance abuse before they passed state laws. That they passed their law, and then they found that there were so many different opinions about how would you identify and what does this mean affected by substance abuse, that it was quite a path for them to try and then fit these definitions into their statute. But clearly understanding what the state's definition of these three populations, clarifying the notification procedures from hospitals, from OBGYNs, to know what that procedure is supposed to be, and then how it is made, the notification, as well as then what does the intake at CPS look like? Is there a procedure that is followed once they have that notification from the hospital that that needs to be standardized and needs to be thought through about how the different populations of families may be the services that are put in place for them. And by those populations, the difference between a pregnant woman who has a substance use disorder, a pregnant woman who is receiving medication-assisted treatment, and a pregnant woman who may be receiving medications that, in fact, the infant may have a withdrawal symptoms, benzodiazepines, for example, that may not have a substance use disorder. How do we separate those populations and know what the protocol is for CPS to put in place their services? In the CAPTA statute, there is not a requirement that CPS is the only agency who can develop and implement, oversee the plan of safe care. A critical role for SAMHSA agencies is for those treatment providers who have pregnant women to engage with their community partners in advance of the birth to make sure that there is a plan of safe care that is put in place before the birth event. How helpful that would be to their colleagues in child welfare, as well as how empowering for families to have their plan before birth if this is a population of pregnant women who may have an infant that could be in these three categories of affected by withdrawal symptoms or FASD. How do we engage families in making those plans in advance? And then responding to those changes in data collection and reporting. I'm sure for the child welfare managers, the Children's Bureau managers, program managers that are reading the annual reports now, I'm sure you're beginning to see some of those data collection challenges in the states and how states are beginning to respond to that. At the local level, then, some of the challenges are related to how to implement these coordinated assessments, looking at the prenatal screening and the different kinds of factors that we've been talking about today in assessment and the components of the plans of safe care. We have some examples. There's not a lot that is out there at this point, particularly related to plan of safe care templates. The states that did have those in place, they were before these most recent changes to CAPTA. We have states that are working on plans of safe care protocols. We have examples from Ohio in particular that made changes in their SACWA system about identifying and reporting for this particular population. We have some examples of both state statutes that have passed and those that have been proposed and didn't pass. But if your states are struggling with some of these different components, please do be in touch with us. If you don't see it on our website, to let us know how we can be helpful to make sure that you have those examples. Again, they're not complete, but they're the beginning of an inventory of what states are actually putting in place that we're trying very hard to make sure that we're staying on top of so that that information can be shared across the states. With that, I think we have time to open up for some discussion. Let me check first with our staff if there are some questions that came in while you're looking at the input that we got from the survey that we asked. Do you know of some initiatives that are going on in your community? These are some of the things that you submitted to us about some of the changes that have happened in your state. So I don't know if there's anyone from that submitted this information that wants to share that in the chat box, or Katie, if there are some other questions perhaps that came in.
We do have one question so far that says, can you speak to any NAS prevention? For example, the importance of having clinicians speaking, referring women in treatment for STDs to use contraception, especially long-acting reversible contraceptives, in order to prevent pregnancies when taking these medications, or the same question for clinicians who are giving prescriptions for opioids.
The two places that I have heard of in which this program is in place is Tennessee, that they have an initiative underway to ensure that physicians who are prescribing to women any of the medication-assisted treatment or that have pregnant women with opioid use disorders. Oh, no, sorry, scratch that part, because the long-acting contraception is for those that are in treatment. We do have some information that came out just this week related to that. They have a website that we can connect you with in Tennessee. And then I just became aware this week that Ohio is exploring some of those program strategies. I can speak to some of the things that we know in the family treatment court arena, that this has been something in looking at comprehensive treatment approaches, that reproductive health has been one of the areas that family treatment courts have been aware of, making sure that participants have access to reproductive health. I think that's pretty standard practice and gender-specific treatment programs that women have access to reproductive health, and that this is something that is a focal point for gender-specific treatment to make sure that reproductive health, as well as all of the healthcare needs of women, are tended to during the time that she is in a treatment program. All right, we don't have other questions that have come in at this point. Let me turn things, well, let me just take a minute to look at what was submitted, because I think that there's some information, particularly from Louisiana, with the clinician toolkit that we'd want to make sure that your colleagues know about. So we can follow up and make sure that that is in our inventory of examples for you to be in touch with us about, and making sure that the drug treatment programs for pregnant women are part of the network that child welfare services and home visiting services are aware of. I often find when I'm working with a state that they may not be familiar in the child welfare system with the single state agencies and the staff in the substance abuse treatment agency at the state level who oversee the pregnant and parenting women programs. They're referred to across the states as the Women's Services Network, and often are the Women's Services Coordinator in the state agency. If your states are not working with the Substance Abuse Women's Services Coordinator, we would encourage you to make sure that that connection is happening. They have a lot of information, they have all the information about the treatment programs that are in their state that are gender-specific programs and those that have specialized services for pregnant women. There is a listing on the website for NASADAD, the National Association of State Alcohol and Drug Abuse Directors, but we can make sure that you are connected to the Women's Services Coordinator for making sure that your treatment agencies are aware of the components of CAPTA that they could be helpful with, as well as vice versa, that the child welfare agencies, home visiting agencies are engaged with the state agencies related to treatment for pregnant and parenting women. Thank you for your participation. We have an evaluation that is going to pop up after we close out the webinar. We would appreciate very much if you would take a moment to complete the evaluation, a way to get in touch with us in the PowerPoint that you received yesterday. We want to make sure that you have from the PowerPoint the various information memos and program instructions that we mentioned today, as well as the way to get in touch with us, as I mentioned on that prior slide. We also want to make sure that you are aware that the National Center on Substance Abuse and Child Welfare have 3 online tutorials in which free CEUs are offered. We have about 70,000 or so, I think a bit more than that now, individuals who have taken these courses. There are, I believe, 7 or 8 states that require the online course of all of their child welfare workers. So first, the number 1 is geared to child welfare workers, and it's understanding substance abuse and facilitating recovery. It takes about 4 hours to complete, and there are 4 free CEUs from the National Association of Social Workers at the end of that. The courses were all updated last summer to add new content related to opioid use disorders and some other changes specifically related to family treatment courts, and making sure that the presentations of these courses were updated. The second course is a guide for substance abuse treatment professionals, and it teaches about child welfare and the dependency court, particularly the timelines, the kinds of information that child welfare agencies need from treatment professionals. And then you see the third course, which is geared to legal professionals, so judges and attorneys that are working in the dependency court and have families that have substance use disorders. And then some of the other resources that are available on, again, on the National Center website. The guide for child welfare workers was intended to be sort of a basic primer that is available for child welfare agencies to download and make part of their new worker training. Some tutorials that are available to you, as well as the additional set of many different monographs that have been produced on various topics, including drug testing and the substance abuse specialists, meaning the ways in which communities organize bringing in the expertise of someone from the substance use disorder treatment agencies or recovery coaches, peer mentors, various models in which that connection is happening at the local level, and pairing that with child welfare agencies and courts. So a lot of resources, again, that are available on our website. If you haven't visited the website, you see the link there on the bottom left. We would definitely encourage you to do that because there are many resources that are available to your state. Again, thank you so much for making the time for this webinar today. We look forward to hearing from you about how the National Center could be helpful in your particular region. Thanks very much, everyone.